This
meeting.
conference will now be recorded.
Creepy. Okay. Would you mind shutting my door? So I have a Dr. Geisler in my office and Dr. Hocamp as well. Dr. Geisler is one of our first year residents, and Hocamp is Hocamp. So it's just us right now. It's like us and Navi and Foster and Becca. It's fine. Okay, I did send an email out to other people for participation as far as the clinicians that were asking for consults. So hopefully they might be able to join at some point. But it also could be, I know they were kind of busy as well. But I'm sharing it, right? Okay, you guys can see my monitor. That has the Ohio State University, hopefully.
Yes.
Yes. Okay, good. Okay. So the first case that they wanted to talk about, and we don't have any actual clinicians here. Do you mind if we just wait for a moment? I wanted to be on time because I know we have a lot to discuss, but I don't really think it's worth it if we don't have any clinicians. Because JD, I know he said he had to step out for a patient, but I guess I can get everything up and ready to go. Probably reasonable.
Yeah, and that's fine with me. I might have a clinician come and join me. She's just uncertain whether she could make this time.
Okay. And we can certainly talk about whether or not we need to. Oh, George is here. Okay, good. If we wanted to switch it around to a different time, but as far as being able to be amenable to the Californians, that's kind of why we have to do it at noon.
Yeah, I think it's going to be hard to make it good for everybody. You know, obviously for our clinicians, 9 or 10 a.m. is a little easier because then they're done with rounds but haven't started seeing patients yet. But that's not going to work for the West Coast people.
Yeah. George, hi, how are you doing? He's silent right now. He's probably muted.
Disorganized. How about
that? I will share a little more information at this case. So, and George, I've invited the clinicians for each of these cases, and they've all said that they were really interested in joining, and they hope to join, but they knew that they were going to be busy as well, so they were going to join as time allowed. But I think because we had 3 cases, it's probably good to hit the ground running and at least have a little bit of update of what we knew from Benjamin Brown. And he is a 9-year-old. If everybody can see my Word document, she just emailed to me earlier this morning. 9-year-old male castrated Yorkshire Terrier. We have an enormous amount of terriers in our database now. And so we're hoping to get another breed associated nephropathy grant underway. But this one's a little interesting because it's a little bit different than what we've seen in other terriers. So, ooh, I don't want the webcam. Go away, webcam. That's literally the back of my. How do I get rid of it? Oh, that's George's webcam. Hi, George. That's the back of your computer.
Well, we can make that go away. Yeah.
And by the way, George, I'm Larry. The way I signed in, it signs me in as Larry because I started this meeting. So.
All right. Well,
okay. We're recording for everybody. For
his appearance has improved.
So it's I think 11 pounds for a Yorkshire Terrier seems a little chubby, but who knows? And he was just going for annual health exam. He was on an Alapril for a previously diagnosed protein-losing nephropathy. And he owner said the dog was completely fine, and they got a UPC at that time of 5.7, and the BUN and creatinine were within normal limits. I'm looking at Hocamp. 0.6 is fine for a Yorkie. She's kind of doing maybe a little high. But he's had previous analyses that has shown The create's been up as high as 0.9. And he's never been hypoalbuminemic, so that's good. But he has proteinuria. And so they did a tick panel that was normal. They did a cortisol to creatinine ratio to see if he was cushingoid, and that was normal. And then lepto-PCR were also negative, and so they did the biopsy. Since then, he's been placed on omega-3 fatty acids. They put him on a kidney diet. He's on enalapril, and he had more recent blood work just 2 weeks ago, and his creat is kind of stable at the 0.5, but he's still proteinuric at 3.3 for UPC. And so based on the case, this is a little bit interesting because on histology, which I'll just open up that stuff now, actually it's pretty bland as far as what I was able to see. I don't think there were a lot of glomeruli. I think it was a fairly limited sample. Let me just verify that. Let's see, we had, I'm not sure who that is. So we had 12 glomeruli for evaluation, and one was globally sclerotic, and the other ones were kind of boring to look at. So I'll show you what they look like. And they're kind of a little bit difficult per se to evaluate if everybody's seeing an HED glomerulus, hopefully.
Yes.
Oh, Campus seeing it, she's in my office with me. Okay, so some of these, and I think when I deal with pathologists, that a lot of times these edge glomeruli can have a little more artifact or distortion because they're literally at the edge of the core. And so they can be a little frustrating to evaluate, but we can definitely tell by the silver stain that we have pretty good smooth contour to our glomerular basement membrane or our capillary loop. And for the pathologists in the room, like Dr. Geisler, you can get closer to the screen if you like. There are, we often we want to evaluate the peripheral portion of the glomerulus and not necessarily the central portion, because that's where we're going to look for irregularities of the glomerular basement membrane. So the silver stain looks really good. And then the PAS stain, likewise, again, no obvious remodeling of the glomerular capillary wall. And then the trichrome was pretty bland as well. And oftentimes in the trichrome, if we're looking for immune complexes and we're really lucky, we can find them on the outside surface, so the abluminal or subpodocyte or subepithelial surface. And I didn't see any of that in the glomeruli that we had for evaluation. And another example of a capillary loop, which nothing that I could hang my hat on to say that this is definitive remodeling or immune complex deposition. So and this is the globally sclerotic glomerulus. It's within a dilated Bowman's capsule, so kind of glomerulocystic atrophy. So I wasn't really that excited about the light microscopy. I don't know what's going on there.
Somebody's having way too much fun, that's all.
I know. So then the IF was interesting though, because it sounded like, and that's kind of when I was hoping maybe I'll get some more information from the clinician, but I was wondering how long the proteinuria had lasted, because she said he had a history of proteinuria, and that's why I was on enalapril. And so the IgG wasn't, so we did two versions of IgG. And so we had a kind of a strikingly positive small edge glomerulus, and then the other one wasn't as positive. So this one has, you're looking for granularity. This glomerulus is a little shrunken. Again, it's at the edge of the core. So you're looking for granularity at the capillary wall, and we have a few granules, but the other one seems strikingly positive. And then the IgA, I kind of burned out the IgA, and that's why I wrote in there that it was overexposed. I left the light on too long for the picture. I think it was brighter than that when I originally took the image. But then the second glomerulus that I had for evaluation definitely had, again, some granularity along the capillary loop. Here would be a capillary loop that is staining positive. So IgA and IgG were there, better in one glomerulus than the other. Lambda was definitely strong, and so this is at edge glomerulus as well. And so what we look for is the granularity along the capillary wall, and then kind of also along the matrix to see if it's granular in there. And so that particular glomerulus was very strongly positive, and our second glomerulus, which is our squished one, is super bright. And you don't even see anything in the background as background staining. So I was like, oh, okay, it's going to be immune complex disease, and maybe it's just very, very early. And so the EM images, I will just pull up the ones of interest. The EM images likewise show that we have capillary loops. They're kind of squished as well. But each one of these little electron densities all along the capillary loop are consistent with immune complexes. And so some of them are kind of linear, and not linear, but kind of taking up more space, and other ones are a little more discrete and rounded. And then these red cells are kind of squished because I think the whole glomerulus is a little wrinkled. And then they're kind of throughout. So all these electron densities here are probably representative of what the granular staining was on IS. The other thing it has, which is kind of the Yorkie thing, where they have this almost like vacuolar change to their glomerular basement membrane. So he still has some weird kind of abnormal glomerular basement membrane to begin with. It's a little bit more prominent maybe on this capillary loop. And then the podocytes here are fused over large portions of the capillary loop. And then we still have a few maintained normal podocyte foot processes. So I was confident that there was immune complex deposition here. The strange thing was that when you have a glomerulus without hypercellularity, the deposits are almost always subepithelial, and so they should be sitting right below the podocyte. And these guys seem to be either intermembranous or maybe even a little bit subendothelial. So usually subendothelial deposits attract a lot of inflammatory cells, and so that's why it has a hypercellular appearance. So this one, it doesn't seem to be obeying any of the rules. It's got more subendothelial to intermembranous deposits without a lot of hypercellularity on light microscopy, and then the positive IF kind of fits to the fact that it is a immune complex disease. So the clinician isn't really sure how to deal with this. I'm not really sure how to tell her to deal with this or suggest to deal with this. It looks like we have a few more people who have joined. Dr. Para is actually discussing another case, so I would like to introduce her. She'll discuss she'll be here for another case discussion in just a moment. And I don't know if I know, Cedric, I'm not sure if I know I've invited you, but I'm not sure where you're from or affiliated with. Are you able to speak? Might be muted. So we have another, but I don't know how to suggest to treat this. Because I guess we could say immunosuppression is warranted. There are immune complexes. We have IF evidence. We have EM evidence. So no matter what, I think a closely monitored immunosuppressive trial is indicated. George, do you have any other thoughts?
Well, the first thing for me to admit is that I've retired and I haven't actually treated a live patient for a living in a long time. So I really shouldn't carry on too much about things I don't do. Nobody should. It would be, as you said, interesting to know a bit more about the background of the proteinuria and all, and the UPCs. We've been run along here, but the sense we had from the beginning was that this dog has had proteinuria for a while, and what's prompted the biopsy is a recent increase in magnitude that seems rapid compared with previously, and that there's a beginning to drink more water kind of a thing. So there is clinically the possibility that this has some new process superimposed on an older or more antedated process in terms of its origins. Now, whether it's true or not, then one can take that and make the story that he has um, the underlying sort of goofy sub endothelial lucency and change that we see that in a lot of proteinuric Yorkshire Terriers, and that recently he's got some immune deposits, okay, which has made the situation different and worse. Now, why it's not as cellular, maybe the composition of the immune deposits is not, quite as aggressive with regard to activating complement and other things that are the amplifiers of inflammation. Or it's possible that maybe the change in the subendothelial composition with the previous illness is muting the response in some way by separating the immune deposits, at least some of them, from the circulating amplifiers of the immune response. It's hard to know, but the thing probably to do is to immune suppress the dog, because there are immune deposits, and I think all immunosuppressive protocols should be carefully monitored for indications of whether they're doing more good than harm or harm than good, and go accordingly.
Yeah, so I can you guys hear me?
Yes, we can.
Yes.
Mm-hmm. Hi, this is Angela Silva. Thank you guys so much for sitting and reviewing this case. Because, kind of similarly to you guys going back and forth deciding, what we're going to do with this dog, we're kind of doing that on our end too. And so half of us, want to begin immunosuppression, and the other half are a little bit more hesitant because of the chronicity of this case. I know that, sometimes the history is hard to convey very well, but, as far as I can trace this dog back, 3 or 4 years now, he's had proteinuria to some degree. And, you're correct in saying that, the recent prompt to really work him up and get these biopsies is that spike, that he had on his UPC, even though it was just a single day sample. The client is just not able to give us multi-day recordings. So, as we track this dog, his creatinine has been relatively stable. His albumin has really been fine, other than, about 4 years ago, we started with an albumin of like 4.2. And now most recently, we're getting into the, 3.9 and 3.6 realm. And so I don't really know if that's starting to show progression of disease. And as his clinician, I would like to immunosuppress him at the best time, immunosuppress him when he actually needs it and it's going to do some good. And so we're trying to decide, is that today? And I think that, from listening to you, it would probably be so. But the other question is, can we just make his numbers better by bumping up his enalapril to a twice a day dosing? He's on a very low amount of enalapril right now. So there's certainly other medications, enalapril or telmisartan, to use rather than having to immunosuppress the dog.
And I have just a really quick question. So, which phone are you calling from? Because I'm having a hard time identifying you on the attendee list.
Oh, I'm sorry. So it should be my cell. You should see an 8473 number.
Oh, it doesn't have it on. Okay, sorry. So I didn't realize that you were on the phone earlier. I apologize. It's not listing you on the attendees. So, the kind of question about immunosuppression for this dog, we often have sometimes where, and I'm a pathologist, so I have to put that caveated. We have more mesangial limited deposits, so different case than yours. And once they start to show progression and their UPC gets worse, or maybe doesn't improve, and the creatinine starts to get worse, that's when we say, well, trying some immunosuppression might help. But there are definitive electron dense and IF positive staining. I think this dog, kind of like George said, maybe always had background disease that was in this low grade UPCs of 1s and 2s, and now has a second disease that was resulting in this spike, and that second disease is allowing or enabling the immune deposits to be there. I assume people would probably start with mycophenolate since that seems to be our go-to drug for immunosuppression. And then if at some point things get better, the one thing that I as a pathologist can offer is that if the owner is willing, then let the dog get rebiopsied. We would evaluate it at no charge. So because we really need to find out how these things improve or maybe don't improve, and that's what we're trying to do now is offer follow-up biopsies or repeat biopsy evaluation at no charge to the owner. I mean, obviously your charge for taking the biopsy would still be there, but we would evaluate it for free. So any other thoughts, George?
Yeah, so the idea of not being cavalier about giving immunosuppressive therapy to this or any other dog is right on, and he's not all that sick. What we're really talking about is making sure he doesn't get sicker or get beyond where we can help him
Exactly.
unnecessarily because we've been reluctant to do what's best for him, I mean, in a variety of things over years in internal medicine, I've taken a relatively conservative approach personally, and I think that when you're in sort of a gray zone, or if the thing that really matters is what happens next, and the monitor. I don't. This example comes from people medicine, but not all immune complex disease requires medicinal treatment to go away. Okay, a third of people with membranous nephropathy get better while they are being treated with what we would call standard therapy. It comes for no good reason, and it subsides for no good reason. It has reasons. It's just we don't know them, so things like falling albumin, rising creatinine creeping up a little bit. It doesn't have to get outside, if you will, the normal range. I mean, if it's been whatever 0.6 or 0.7 and something like that, and now it's 1.1, it starts worrying me. I'm making up numbers. I'm not actually looking at yours. Okay, but I'm using those concepts. So if we're on the fence, the thing to do is to monitor the consequential variables and respond early if they begin to trend in a way that is headed for trouble or disaster. And another piece is the dog and the client. Some things are right in some people's wheelhouse, and some, that you just know that this isn't the client who's going to be comfortable with things going bad if they do or whatever. So there's a variety of, and I don't need to tell any of you about dealing with the variety of clients and circumstances that you see every day, but those factor into this besides the numbers on on the tests when they come back.
And Dr. Hokamp also mentioned, so one thing we could do is run the SCF page to look at the size of proteins that are going through the urine. And so we do that for often in conjunction with the kidney biopsy, but we could start doing that and maybe monitoring this patient and seeing if it's more high molecular weight proteins, and then we actually are concerned about the degree of glomerular damage, or is it kind of a spread or possibly even just low molecular weight proteins. So that might be a one non-invasive test to do that would maybe help monitor. If you decide to do treatment, it would be great to get a pre-treatment urine sample and then a post-treatment or mid-treatment urine sample to see if there's been improvement, and that might help you see if you're making the right decision. I'm not sure if you have an SCF kit at your practice, but if not, we can send you one and you would get it tomorrow. If you'd want to submit that, and that would be at no charge because we have a biopsy already from this dog. So
okay, yeah, I don't at the time of doing biopsies, I was getting a little confused as to what functionality that caused. So I think we just kind of decided to do the standard biopsy kit. But I can email your technician to see if she can send me one over.
Yeah, that sounds great. and then we could, and tracking, and I know she's been Dr. Hokamp, she's sitting in my office right now, but she's very interested in having serial samples, just so that she can see how that changes over time. And this one is a little bit like of a different case than we're normally used to because of our suspicion for ICGN having certain bands, and it would be really interesting to see if this one had that band. Yeah, deposit. So that sounds like a good plan for yours, and let me know. Well, obviously, as I said, I know JD Foster was going to be in and out, and I've already sent this history and report to the other people that sometimes attend this conference. And so if they have other input or other guidance, hopefully they'll be able to email you as well for suggestions.
Yes, thank you so much. I really appreciate it. So, if we begin the mycophenolate dosing, the only question that I had was, I was planning on bumping up his enalapril dosing to the twice-a-day dosing. Do I still need to do that if we use this mycophenolate, or should I just change one thing, see the UPC back in 3 weeks, and then decide from there how to adjust the ACE inhibitor?
Again, this is theoretical because I don't actually see patients anymore. But my predisposition would be to optimize, at least from what I think is optimum, the non-immunosuppressive therapy first. Get yourself a baseline, and then know what you're doing there, and if you decide to add the mycophenolate, and whether you just increase the enalapril or consider telmisartan or whatever.
Mm-hmm.
I mean, the idea about I think with this dog whose clinical condition gives you some room. I mean, you time-wise, you're not worried about his cratering before the weekend kind of deal.
Right.
The idea it would be to optimize the standard therapy, get as much going in his to his benefit as you can with that, and then add the mycophenolate in on top of that.
Okay.
I mean, fair. That makes the most sense to me.
I agree with that.
Yep. Excellent. Thank you so much. I really appreciate it.
Thank you. I think now I see Dr. Para is still here as well.
Yep.
Did I say your name correctly?
Yep, Dr. Para. Can you hear me?
Yes, we can.
Okay.
And you had requested about Gunnar Graham as well?
Correct.
Okay. Do you want to give a brief synopsis or anything about that?
Yeah. Gunnar is a 2-year-old male neutered pit bull mix. He's about 36 kilograms. He had an interesting history prior to coming to me. About a couple months prior to coming to me, he had seemingly gone blind by his and was determined by ER to not be able to see, and they thought there was bilateral retinal detachments, but at that time I think blood pressure was up and down. It wasn't convincing that he was hypertensive. He saw an ophthalmologist, and by that time he had regained his sight, and blood pressure was normal. I don't have numbers for you right now, but and around that time blood work was checked and he was found to have some azotemia. His blood pressure was 200 initially and then had come down to like 160. And his BUN was 45, creatinine was 2.9. The UA at that time showed, I would have to look it up, but the UA at that time, sorry, I have to look up the USG, but that's what I have in terms of his renal values. So he was seen by the ophthalmologist and determined that his retinas were no longer detached and that he was visual. He had proteinuria, and I can tell you the degree in a second. 4+, and I think it started out at a UPC at 4. and he was sent to me to evaluate for that, even though he was doing better clinically and was no longer blind. Had a resting cortisol that was normal, and I'm just getting up his labs, and I'll be able to tell you. Albumin at that time was 2.2, so there was some concern. He had a 40x that was negative. And it came to me when his UPC was 4. This was about a month and a half after he had that episode. And I rechecked his UPC, and it went up to 16.6. And his albumin at that time was 1.4, and globulins was 2.3. The interesting thing is that he was also having some GI signs. He had developed 1 month of diarrhea, which was new for him. I sent out an IDEX PCR that was negative for infectious disease. His blood pressure was 160 systolic on a Doppler, and we started enalapril and aspirin and fish oils and renal diet. And then 3 weeks later, his UPC came down to 8.8. So I was happy with that. But then I checked it again 3 weeks later, and it was still 8.8, at which time we decided to go for biopsies. We biopsied both his GI and his kidneys. His GI was moderate lymphoplasmacytic, eosinophilic, and neutrophilic enteritis with mild lymphatic dilation.
Okay.
Yeah, and that was June 27th when we did that.
Okay.
And we did full thickness and surgical wedge biopsies.
Okay.
Of the kidney.
Yeah, we'll probably add some of that information to the history, as well as having the GI biopsy as well. Did you send that to Texas A&M's GI lab?
Cornell.
Okay, Cornell. Okay. So these actually are, in contrast to the last case, quite stellar glomerular changes. And so the H&E, as everybody knows, is very difficult to interpret, even to see where the cells are. You have to have a lot of practice to figure out which cells you're talking about. But I think it is kind of also a feature that we have noticed sometimes, that in primary inflammatory glomerular disease, there's often like a rim or a cuff of lymphocytes and plasma cells outside Bowman's capsule. And so that can be another kind of, interstitial inflammation, kind of always a patchy pattern, but when it seems to be periglomerular, I get concerned that something is going on with that glomerulus. Here is a silver stain of that first glomerulus I showed you. And what's seen is that a lot of these peripheral capillary loops don't have good lumens. I know I'm echoing to myself. Am I echoing to you guys?
No.
Okay.
Not to me.
So there are capillary loops without really easily observed lumens. Here's a red cell. We should see a lot of these inside the capillary lumens, and because these things are so full of cells, the red cells can't get through there. We have some adhesions between the glomerulus and Bowman's capsule, and there's just a lot of cellularity. It seems to be both in the mesangial region and then also, like I said, in these capillary loops, so that red cells can't be there. And then the PAS stain is a similar way as the silver stain to look at where the cells are located. So we have, I am echoing a little bit for Texas A&M, so I'll pull the phone a little bit from my mouth. I wonder if it's because it's echoing through somebody else's speakerphone. Okay, so we have the cellularity that's in the mesangium and the capillary, and this is actually a podocyte here, and he's got some protein droplets inside of his cytoplasm. And then if we pick and choose which capillary loops we're looking at, we can see a lot of complexity to the loop. And so here's one where you have a lot of almost like weaving or double layers of the capillary loop, and that would be in contrast to, say, this loop that's very smooth and has a good smooth surface. So we want to see the good smooth surface. We don't want to see this complexity, and this complexity kind of jumps out at us on the stain. And then again, great, really quickly, great protein droplets in some of the podocytes. So the podocytes are very injured. Trichrome, again, is just highlighting the exact same stuff, the hypercellularity, the protein droplets in the podocytes, and then these adhesions between the glomerular tuft and Bowman's capsule. And so the light microscopy is very consistent with a proliferative, a hypercellular pattern. So the hypercellularity means proliferative. And then the complexity of the glomerular basement membrane puts it into a membrano-proliferative pattern. So we were pretty confident we were going to see immune complexes, and we did.
Hey, Rachel?
Yes.
This is Rebecca. I'm just curious if on light microscopy, if you saw any vascular changes.
That's a very good question, and I have to actually say that Shannon read this biopsy, and it's not commented on there, but I think she hasn't sent me the slides back, but it would be really interesting to look given the blood pressure of this dog. So
right,
I
and
will
like on the first glomerulus you showed, it had that kind of hyalinosis change, and one of the periglomerular arterioles maybe looked a little plump. So I'd be interested to see if there was vascular lesions in the renal interstitium that would be consistent with hypertension.
And I agree, and I think the fact that we have a good wedge with a large amount of tissue is going to be good for that. So she has not sent me these slides back after she read them, but I will ask her.
Sure.
The IF is, hold on one second, was positive, and we are looking here. So here we have a great glomerulus, and all of these little granular staining things are immune complexes. They're on the capillary loops, and they're also within the mesangial matrix, so they're kind of throughout the glomerulus. And we're doing both an old and a new antibody, so I just kind of compared the two. The IgM, actually, this is, so we often talk about how IgM sticks to everything, and I think that sometimes in a immune complex GN like this, actually IgM is weaker than the IgG. IgG is kind of taking over. There's not much IgA. There is evidence of complement activation along some of the capillary loops as well, so that's probably part of the reason we have such a hypercellular appearance. And then the lambda light chain, which is always our most beautiful antibody, stained very positively as well. So we knew it was immune complexes based on IF, and then the EM was also gorgeous as far as the lesions. And I apologize when I'm a pathologist talking to a whole bunch of clinicians, I forget myself. But we have some capillary loops that look like they're doing pretty well. We still have some red cells that are able to circulate through them. And then we have entire capillary loops that are just completely collapsed or even squished or effaced by the presence of immune deposits and that cellularity that's in there. So these immune complexes are kind of in many locations. So they're on the outside, the subepithelial zone, and then they're on this area here, which is probably subendothelial, and that might be the remnant of a previous capillary loop. Let's see, there's a couple here. It's even hard. I remember when I talk with the MDs about this disease, they often comment that when you have this type of deposit, the capillary loops get so filled up so quickly that oftentimes it's hard to say, am I in a mesangial zone or am I in a capillary loop? And you just kind of get lost in the glomerulus. And this was a capillary loop at one time. Here was our endothelial cell. This might just be a part of a circulating granulocyte. Here's definitely a circulating neutrophil that's going through and that's being attracted by these deposits. So the deposits are there. They are in multiple locations in this dog. And so in that situation where we have them on the inside of the capillary loops and then also on the outside, like in this particular glomerulus, capillary loop, we often say it's a mixed pattern. So it's on the inside, it's on the outside, it's in the mesangium, and so we say it's a mixed pattern. And so for this kind of aggressive, and it's also kind of behaving in an aggressive fashion in this dog, immune expression is the best option for this. And have you guys already started any immunosuppressive therapy for this case?
Mm-hmm. I have. I started prednisone initially because when I got the GI biopsies back, I was like, okay, at least I'll start prednisone. And then about a week later, I started mycophenolate. The odd thing about this, and I don't know if anyone can comment, but 1 week after the renal biopsies, so I checked his UPC just prior, and it was 8.8. That was about 3 days prior to the renal biopsies. And I checked it 10 days later, which is 7 days after the renal biopsies, and it went down to 2.2, which I could not make anything of. I was really surprised. His albumin was 2.0 at that time. And I said, okay, well, we won't do anything right now. And I checked it a week later, and it went back up to, I think it went up to 12.3. So I don't know what that was about, but the fact that it went up to 12.3, I added steroids at that point, and then mycophenolate basically a week later. And so far, I've gotten down his most recent, about 2 weeks after mycophenolate, his most recent UPC was 10.9, just down from 12.4, so not improved yet. And I've been tapering back the steroids because I don't know if that's complicating the UPC. Or complicating the proteinuria.
Yeah, because and I think that's the annoying thing, and that is the difference between dogs and humans. So, in humans, the steroids don't make them proteinuric, and so that's one other thing that we have to fight against is that if they're on steroids for another reason, or maybe just to kind of quiet down interstitial inflammation, that's going to make the proteinuria worse. And I honestly, I mean, that's part of the reason we're trying to get a lot of these conferences together so that we can talk about more of these pieces, because we need to be following these patients. I think we're putting a lot of dogs that have evidence. I mean, they have distinct evidence of immune complex disease, and we're putting them on mycophenolate, or sometimes we're going a little bit more heavier drugs like Cytoxan, and some anecdotally do well, but I honestly think there's a lot of that they're just hovering in this kind of plateau phase, and we don't have enough data yet to make any assumption that these are effective drugs anyway. We're just going from the fact that they're effective in humans. I know we've had a case that we've been treating for quite some time, and Dr. Foster has been giving us, I think we've had at least one follow-up biopsy on a dog that's had immunosuppressive therapy for about 5 or 6 months. And the deposits in that dog were only on the subepithelial surface, and they're still there. Like they're still like 5 or 6 months after immunosuppressive therapy, I can still find deposits. And the dog is, kind of, his UPC is lowered, but it's definitely not normal. So I think that you have justification for using mycophenolate, and it's just whether or not, how long do you have to use it, how often should you be testing the UPC, and in conjunction with the use of the mycophenolate. To speak to Becca's point, I'm not sure if she's still here. Dr. Conkin loves vasculature, and so we were talking about the arterioles and the arteries in the biopsy sample, the light microscopy. There is a lot of evidence of in the capillary wall that hypertensive episode kind of damaged the capillary. And again, we're taking this knowledge from human medicine, but it's this kind of lucency along that subendothelial layer. So this clear space here is seen in humans that have hypertension or had hypertension. And then what happens is the endothelial cells start to then synthesize new basement membrane as well. And so we'll see this kind of double layered as well, just even secondary to hypertension. And so I think that these glomeruli did get hit by that hypertensive period in this dog.
Thank you, Rachel. That's really interesting.
Which I don't understand why a 2-year-old dog would have an episode of hypertension. I was always thinking that the kidneys came first, and then it was a response to that. So.
And it very
that's
well,
not, that's
know,
not,
I don't know when the original fight or the original. So, did you ever have a UPC during that original hypertensive episode?
No, but there was proteinuria.
So maybe it was kind of a combo thing, and then what we're seeing now is the residual effect. And this stuff, whether this goes away and how long it takes to go away, the hyaline change and the capillary wall change, if it does go away and how long it takes is not something we know. So Dr. Lees, do you have more advice as far as this particular case? Is he still on the phone? Hopefully.
I'm still here. I'm not sure I got advice. Maybe just a couple comments. First of all, having gone to a lot of hung around with physicians in nephrology meetings and whatnot, the idea in veterinary medicine that hypertension is a cardiovascular, domain of the cardiovascular people or cardiovascular problem, that never, sort of jived with what I observed in the nephrology world. They always think of hypertension as a part of kidney disease, and the physiology text would say that hypertension is failure to excrete sodium adequately at a normal pressure through the kidney, and so I think so. That my point is, I think the original episode, even if it came to medical attention because of altered vision and concern about retina and high blood pressure and whatnot, the kidney was part of the problem from the beginning, and it was all wrapped together in one complicated package. And with regard to treatment, I mean, what you're looking at there is partly injuries to the glomerulus mediated by high blood pressure. I mean, there is hyperperfusion, hypertensive injury to the glomerulus. You can do that experimentally without immune complexes. We have immune complexes and an inflammatory response to that, which based on the amount of antibody that's stainable in there and the complement and the number of neutrophils that have responded, this is a hot fire. Okay, and the immune mediated components of the damage, in addition to the pressure and flow mediated components of the damage, is substantial. And the third thing is that even if you shut those things off, you've got a lot of structural abnormality of the glomerulus that would need to be repaired. And this is not a place where the structural proteins turn over quickly, and the epithelium and endothelium is restored quickly. I mean, the podocytes are they probably do replicate, but not very often, and not very rapidly or very well, and things like this. So even if so the idea of the corticosteroids to sort of throw some anti-inflammatory effect on top of a hot inflammatory process for a little while until you get the immune complex components of it to subside, and get the blood pressure down. But after you do all that, you've got a lot of structural change that has to get reorganized and repaired as best it can. It will, the ones that we see that are immune complex that we treat and they return essentially to normal are the very early, albeit florid, membranous cases with lots of immune complexes but little structural change. You shut that off with medicine, and it might take a year still, but we've had dogs go back to virtually normal values in both creatinine, albumin, and UPCs below 0.3. But when you have lots of structural change and all this stuff that you're looking at, it's going to take a while. And making it better is our goal, but our first job is to make it stop getting worse, and then go sideways, and then maybe get better. And we're going to have to be patient and modest in our expectations.
Okay, thank you very much. It's very interesting to know how significant the hypertensive lesions are. I found it interesting that this dog also had developed diarrhea for about a month, kind of acute onset, and also had those changes on biopsy. And I didn't know if that was part of this immune disease going on. Yeah.
Is the diarrhea better?
It's better, but not resolved. So.
Yeah, I think, and also if you wouldn't mind, since we have a lot more detail, clinical detail in this case, if you wanted to forward us the report from Cornell, that would be great. We would append it to our database. We have a few of them kind of do this where they have it. We get a combo kidney and gut biopsy from some animals, so it would be again good to see why. Let's do a case study on all the cases that we get combo biopsies on.
And Gunnar has a backstory that is more that is available, is more detailed and before the biopsy. And I'm the guy who writes up the clinical synopsis that is seen in the report, for instance, based on the information that comes along with the tissue when it's submitted. But he has a significant backstory that's not, I mean, the last 2 months or whatever before his biopsy was taken has a lot more going on in it than comes across in the clinical synopsis. And if you would have the time to get that to us, we can get it into his story in our record so that when people go back and look at cases and try to figure out things to apply to other cases, it would be more
just like a paragraph summary you would like.
Yeah. The more you summarize it, the happier I'll be, because I've got to summarize it. But you know, if you just read the clinical synopsis that I was able to prepare, it doesn't tell anywhere near the whole story of Gunnar's illness. The hypertension and stuff. Huh?
And my last to do would be to look at the sample when it comes back from Shannon, to look at the vascular changes in this patient and see if we can document some of those things that might be in the renal parenchyma.
Okay.
Well, I feel like this was a productive meeting, and I know we had one more case that the clinician wanted some advice about, but he wasn't able to call in. He's in the UK, so he wasn't sure. So I might just reach out to the group and kind of ask for advice. That was an FSGS case, to ask for advice about treatment for that. And then Dr. Para will have, again, some follow-up with the clinicians that kind of consult for our service. So Dr. Foster usually is happy to email people and give some guidance about immunosuppression. So you'll probably get an email from him as well. And then like I said with the previous case, if the owner wants to consent to a follow-up biopsy, sometimes we have a situation where we've done a biopsy and then 2 years down the road, the dog eats something and they're going in for, to get a foreign body removal. And while they're there, they remember the dog had kidney disease a long time ago, and they'll send us the sample a couple of years later. So we do have a couple of great follow-ups. And we evaluate those for no charge because we really need to make it as easy as possible to get these additional samples so we can see either effectiveness of treatment or progression of disease. So, but is that pretty much good? And we'll just make sure that the clinicians reach out to you and also to Dr. Silva as well. I think she's already left the phone. She might have.
Yeah, that's great. And I will get you the summary and the report within the next couple days.
Okay, that sounds great. Thank you for calling in. We appreciate it.
Thank you very much.
Thanks. George, I have a lot of work to do, so I promise I'll work on it. Got a lot of cases.
Well, I'm here to help any way I can, but are you doing okay?
Yeah, everything's good. We just had a lot of backlog because our histo lab just got understaffed very quickly, and so we had to switch to have the EM samples evaluated at the med school. So now the med school's cutting my EM samples for the next couple of months, which is great because they're amazing samples. But it's a delay in trying to get that organized and the agreement and the payment for that. So so I scoped like 15 cases yesterday, and we got like another 6 cases this week. So.
I'm in trouble. I'll be
Sorry.
up late. All right.
Okay, thank you so much. I'll talk to
Hey,
you
Rachel.
later. Yes.
While I have you on the phone.
Is it Becca? Okay.
Yeah. Did you get 2 heart slides from me?
I do. I have them on my desk.
Cool.
Jenny scanned them in, and they should be in the cardio folder.
Oh,
do you have access to CV and the perio? Like that?
Huh?
You have access to the slides on a perio, right?
Yes, I do.
You scan them
so they're
in,
up there
in the cardiology thing, and then we scanned the other one you wanted from that pulmonary thrombus, that PT.
Yeah.
one more slide. So we scanned that as well. And then we've had, I know Allie emailed you about the dog that might have storage disease.
Yeah, super cool.
So, and then I think we have another one that needs to be scanned. We have a lot, so we'll have a lot to talk about in cardio round this month. And can I ask you one more quick question before you go? When are you coming to Columbus again?
October 2nd.
Okay, I'll put it in my calendar to make sure that we stay in town.
Sounds good.
Okay, I'll talk to you guys later. Thank you. Bye.
Bye. Thank you.